नमस्कार, गुड इवनिंग, अभिनंदन। ज्ञान प्रवाह की इस पावन धारा में आज फिर हम मिलकर एक नई लौ प्रज्वलित कर रहे हैं। ज्ञान, अनुभव और प्रेरणा तीनों के संगम से उभरती है नेतृत्व की वह ज्योति, जो मार्ग भी दिखाती है और मन को भी शक्ति देती है। हर शाम हर शाम 8 बजे की यह यात्रा सिर्फ शब्दों का आदान प्रदान नहीं, बल्कि सीखने, समझने और आगे बढ़ने का एक उत्सव है। आज की इस कड़ी में हम नेतृत्व, शैक्षणिक उत्कृष्टता और जननांगक्षय यानी कि जेनाइटल ट्यूबरक्लोसिस जैसे अत्यंत महत्वपूर्ण विषयों को छूने जा रहे हैं, जहां ज्ञान ही उपचार है और अनुभव ही पथ प्रदर्शक। आइए इस बौद्धिक प्रवाह में मन को स्थिर कर कर, विचारों को विस्तृत कर कर हम आगे बढ़ें, एक नई अनोखी प्रेरक यात्रा की ओर। ज्ञान प्रवाह। वेलकम टू ज्ञान प्रवाह, a gentle stream of wisdom that flows every evening, bringing with its new colors, new insights, and new reflection for the mind and the spirit. We learn from legends that leadership at its finest is a blend of knowledge, humility, and the service. And when guided by a true academician, it becomes a beacon that shapes generations. And in this same spirit of learning, we also touch upon an important chapter of women's health, that is, today is the genital tuberculosis, where awareness becomes prevention and understanding becomes healing. So let us journey together through stories, sciences, and inspiration. Today's episode is 304. It's a very special. For this, we begin with a heartful reverence to the visionary, guiding Presidential Initiative, Dr. Sunita Tandulwadkar, a leader who brings grace to every challenge, clarity to every vision, and a warm, transformative energy to the entire FOGSI family. Ma'am, we welcome you with a deep respect into the rhymes of today's Gyan Pravah. And, Madam, today we are truly privileged to host a towering figure in the medical education, Professor Dr. Subodh Katyar, Sir, a teacher of teachers,
Thank you.
a principal who shaped generations, a clinician whose commitment is lifelong, and a leader whose journey continues to inspire. Sir, it's an honor to have you with us and share your wisdom, your stories. Madam, few words about Dr. Subodh Kumar Katyar, sir. He has been a principal, GSVM Medical College, and the Dean, Faculty of the Medicine, CSGM, University of Kanpur. Was born on 28th February 1948. After his early schooling at Kanpur, he did MBBS from GSV Medical College, did his DTCD and MD, and joined as a lecturer in 1975. After that, he became in 1980 professor and head in 1990. Later, he took over as the principal and the dean in the same college in May 2003 and served till 28th February 2008. He has held several prestigious positions. His CV is very long, but I am highlighting few important points. He was the president of the National College of the Chest Physician in 2003 and 4, Tuberculosis Association of India, NetCon in 2007, Indian Chest Society, Indian Medical Association, UPTB Association and Asthma Welfare Society of the Kanpur. Presently, he is also the chairman of the Central Zone National College of the Chest Physician. He was awarded for his so many research papers, and Renbexy Robert Koch Oration Award of the Tuberculosis goes for him. He had many keynote and orations and many research works. To his credit, he has been recipient of the several prestigious awards and honors, which include Excellence Award in 2005, Pursuit of Excellence by Merchant Chamber of Uttar Pradesh of exemplary contribution in the field of medical sciences and the public health services, Gold Medal of the UP Tuberculosis Association of R. Krishna Memorial Award of Tuberculosis Association of India, Chikitsa Shiksha Ratna Award of GSVM Medical College, Kanpur, Lifetime Achievement Award of 21st Century Motion Art and Stellar Entertainment, Gold Medal of Tuberculosis Association of India. I'm reading very less of his CV. It's great CV, sir. You have been awarded by the Economic Times, by the Dainik Jagran Ayushman India Lifetime Achievement Award for Excellence in Healthcare and Medical Services by the Health Minister of UP government. He has immensely contributed to the research and over 120 scientific publication to his credit. Such a long CV. He has been associated with several important international and national research projects. So, sir, we are blessed to have you. Ma'am, please bless
Thank
with
you.
few words of wisdom.
Thank you. Thank you. Thank you, Katiyar sir. Thank you and welcome on the stage of FOGSI. It's one of the fantastic organization of 46,000 gynecologists in 292 societies. It's fantastic. And Kanchan, thank you so much. The way you speak, the way you merge the Hindi and English, and I can't even understand your few Hindi words which you used for genital tuberculosis and all. You're a master, darling. And always very dependable, very loving. Kanchan, thank you so much for getting Dr. Subodh with us. I'm sure this podcast will be educative as well as with the experience. I think it will be taking a different journey altogether. Thank you, sir, and welcome. I joined just to welcome you all and to show our deepest gratitude and respect to the faculty, sir.
Thank you very
Thank
much.
you, ma'am. Thank you for
Yeah.
words of wisdom.
Thank you. And I'll join the viewers link. Thank you.
Thank
Bye.
you, ma'am.
Bye-bye. Well, I would
Yes,
like to express my heartfelt thanks to FOGSI and to the President, Dr. Sunita Tandulwadkar, for the very kind words and for giving me this privilege, I would call it, of being the guest on today's podcast. I think this is 304th one. It's creditable to
yeah,
have the one podcast every day.
every day, sir.
Yeah, it's
And
truly an honor.
as you see that she has joined, whether she was in the marriage or some
Yes,
function
oh
or
yes,
in,
that shows her dedication. Yeah. Mm.
so
It's
we
truly an
are
honor.
blessed. We are blessed by your gracious presence, sir.
I deeply appreciate this thoughtful initiative taken by your president to bring
Thank you, sir.
meaningful discussions to the forefront every evening. And my sincere thanks to you for a wonderful introduction of myself. And finally, my gratitude to all the viewers and listeners. Thank you for joining us and for your continued interest in learning and advancing together.
Sir,
Thank
thank
you.
you. We are really blessed by your words of the blessings. Sir, starting the discussion, sir, you have held some of the highest leadership position in the medical education and the public health. How would you describe your journey from a young medical student at GSU Medical College to become principal and the dean of the same institution?
Yeah, I think it's a great honor and perhaps a great privilege because I think very few people will have this kind of an opportunity. It's a great thing. I just cannot express myself that being a student who joined this college in the way back in 1965. That is, I think, around that was 60 years back,
Right.
and had his entire career there, and ultimately retired in 2008. So it has been a long and nostalgic journey for me.
Right.
I joined in 1965 the MBBS course after passing out my intermediate, because those days that was the basic minimal qualification was intermediate,
Right.
and I passed out MBBS in December 69.
Oh,
And then after internship, I joined the Department of Tuberculosis and Chest Diseases, as it was called at that time. Completed my DTCD, Diploma in Tuberculosis Chest Diseases, in 1972. And then was awarded MD in Tuberculosis and Respiratory Diseases in 1974. Thereafter, I served as a registrar for, I think, about a 1 year period. And then I joined faculty as lecturer in 1975.
great
And you
journey.
can imagine, from 1975 to 2025, this just completed 50 years
Oh,
in 2025. And I celebrated my golden jubilee as well this year.
great, great. And I born on 1961. 69 you passed out.
And promoted as reader in 1980, as you said, and professor head in 1990. So that was as far as my department is concerned. In the year 2000, I was given an additional charge of proctor of the medical college, a very difficult job to perform, to handling all the undergraduate students, about 1,000 or so,
Yes.
and the postgraduates, about 350 postgraduates. So it's a
Oh,
tough job, really. And in 2003, I was given the responsibility of principal cum dean, Faculty of Medicine of GSPM Medical College. And it
great.
was not just a professional milestone, but deeply emotional moment for me. The institution where I had entered as a young undergraduate
Right.
with dreams and determination had now given me the opportunity to lead it from the front. And that
Right.
was really great thing. I consider it a profound privilege, a chance to serve the very place that shaped me, and to give back to the system that had given me everything. So, I mean, you'll certainly like to do your best for the institution where you had your entire career. Taking this responsibility taught me some of the most valuable lessons in leadership, Dr. Kanchan.
Right. Yes, sir.
Leadership, number one, the leadership is not just about authority, but about accountability. That is very important. Every decision must uplift the institution.
Right.
We have to keep in mind that whatever we are doing for the institution and for its students
Great.
and staff,
Great.
of course.
Great.
Two, a leader grows not by commanding, but by inspiring others.
Very
So
right.
you have to see that you can inspire others, and that they give their best performance.
Hmm.
And three, respect for colleagues, compassion for students, and commitment to academic integrity. These are the three pillars of which any medical institution should stand, really. So
And
that is in brief about my journey as a principal of the same medical college where I did all my studies.
I think because of these, your all the idealistic thoughts, you were the ideal for all of us. We student always used to praise you and want to make ourselves just like you, sir. Great learning
Thank you very
education.
much.
Thank you.
Thank you.
Why did you choose, sir, the medical and the tuberculosis and the pulmonary medicine as your career?
Well, this was again a very difficult. This was a very difficult decision to be taken by me, because I I did well even with mathematics. I scored a very good percentage of marks,
Oh,
and I had a love for biology as well.
Right.
And after even once you pass out high school, then your branches bifurcate. Either you go for a medical branch, you take biology, or
Yes.
you can take other branches, economics or mathematics or whatever it is.
Yes. Yes.
So it was a difficult decision for me to take because my father was an engineer from Banaras Hindu University,
Oh,
and and at the same time, my grandfather in those olden days was a doctor. He was a civil surgeon in those olden days when the civil surgeon used to be the chief of the district.
okay.
And I was not able to decide what to do. Even I had to take help of a psychology and career counseling center to find out what kind of aptitude do I have.
Right. Right.
But beyond this analytical evaluation, there was a deeper question.
Ah,
What kind of life did I want to live?
yes.
That was a very important thing. Means and ultimately, what do I want to go for?
Right.
Um, in fact, my family members
Yes.
and my father wanted to see me that I join a medical side. For reason being that there was no medico in my family at that very stage.
So
Everybody
you
was,
adopted as a medical.
my brother was also engineer. My other two brothers were in business, and uh, everybody wanted that I should take up medical profession as my career, and and I too thought that perhaps I think I had a liking basically for a medical career because I would be able to serve the society through this profession. That was the basic thing that could have. I think this is the perhaps only one of the professions where you can serve.
The learning to. Yes, sir.
Yeah, you can work and simultaneously you are serving the society as well where you live. So that is one big plus point as far as the medical profession is concerned. If I become a doctor, I could dedicate my life to help people, and this is what ultimately I chose. So that is how the decision was taken, and I joined medical college. And luckily, in the first attempt after intermediate, when I appeared in PMT examination, I was selected and got Kanpur. I was also selected in AFMC, Armed Forces Medical College. I was selected simultaneously in Ludhiana also. So there were several. I appeared in several examinations because you are never sure what is going to happen. But luckily, I got, and I was the youngest in my family, among four brothers. So everybody wanted me to be near Kanpur, and luckily I got ultimately Kanpur Medical College, the GSM Medical College, which I used to appreciate while passing through it.
So that gives a great learning to all of us that if you are keen in anything, you can, as you achieve the highest position, you not even entered in the medical field, you joined in your own interest branch and you attained the highest field and joined as a principal. It's a great learning lesson for all of us. During your administrative career, sir, do you describe how do you describe your leadership, vision, philosophy, and achievements? You had a lot many achievements, as we all were seeing it.
Well, um, after my MBBS, when it came to deciding the branch,
Yes.
I joined tuberculosis and chest diseases, and everybody said, "Why am I joining this particular branch?" Because people thought that I mean, nobody looked at this subject as an important subject.
Right.
And moreover, uh, this was a branch which can cause which where there is always a fear of infection also occurring,
Right.
catching
Right.
infection.
Yes.
And then there was not much to do in tuberculosis. There were only three drugs. They said three drugs. You have to only when you've got nothing to do beyond three drugs: streptomycin, isoniazid, pass, and sometimes thiazidone. But gradually, as I went through different positions, ultimately taking over as principal and dean of that medical college, it was not very. I was not very happy with the. To be very frank, I was not very happy with the current status of education going on in the college. And I thought that my first emphasis would be on academics in the college.
Great.
Um, because there was students were not really they were not taking too much interest in their teaching, attending classes, going for they used to call it mass bunking
Mass bunking.
before the festivals, that they'll all disappear 2 3 weeks before the festival really. And all these things, I mean, a lot of indiscipline was also there.
Yes.
So I placed a strong emphasis on student education and kept it as the top priority. What I meant was there should be regular classes, quality teaching to attract students, discipline, and academic sincerity. These were, I thought, were the main central pillars as far as the medical college, as a medical institution is concerned. We wanted to strengthen the classroom attendance so that the students are in the lecture theaters and not away. And we made attendance compulsory, certain percentage of, say, 80% attendance compulsory for appearing examination. And we followed it strictly so that they start studying. Uh, and we also um, did not allow some of the students to appear who were not regular in their classes. But this was not really a kind of punishment, but it was an investment for their future, because if you are not studying, if you are not attending your classes, then you are not going to be a good. I mean, you may pass out ultimately, but you cannot be a good doctor. Uh, I worked relentlessly to modernize the teaching and learning process by introducing new teaching aids, upgrading lecture theaters, and also what we did was that we planned out a 5 years timetable to be given to the student when he enters the medical college in first year, so that different examinations, when the different sessions and what time examinations will be held, and ensure that these examinations are not postponed. Whatever date is shown in the curriculum, we'll stick to that date, and the examinations will be held, so that they don't take liberty of not studying. Because just what used to happen was just 2 3 days before the examinations, a bunch of students would come, sir, to the principal saying that we postpone our examination. We have for giving different kind of reasons. So that was the kind of practice which I thought was not in the interest of the institution.
So, according to you, putting these type of policies could reduce the incidence of mass banking, and the student could be more regular. And thank you for elaborating this all.
And then
Um,
I also thought that it's not only academics which is important when it
yes.
comes to students, because they are away from their home. The medical college is their home now. So I wanted to have a kind of holistic development
Oh,
of these
great.
students.
That is
That
the
was very important. We encouraged entertainment activities, sports, cultural programs, and different kind of celebrations like festivals and New Year and everything was being celebrated in the campus so that they feel the campus becomes quite vibrant and they feel very happy, homely. They don't desire to go back to their home to enjoy.
That
They
is
get
the
the same
great
enjoyment in the
vision.
medical college.
That's a great vision, I
Yeah.
can say.
So I always believe that a principal should be more than administrator,
Right.
a guardian, a mentor, and a constant support system. My doors were always open to these students. They can contact me anytime in the office or at home at any hours. I worried about their careers, their well being, and their future. And I made it a point to remain accessible, sympathetic, and involved towards their career. They should feel that we are genuinely interested in their welfare. That if that feeling goes in, then you can ask. I mean, then you can get anything done because they are very creative people. You can get anything done then.
I really appreciate your vision and philosophy behind this. That's the reason that you got these all achievements. Still now, you are very favorite of all of us. I
Thank you.
see in IMA everywhere in Kanpur, you are very favorite because of your this policy and this very thought. Sir, you have led the major national organizations like National College of Chest Physician, Indian Chest Society, and Tuberculosis Association of India. What was the core input into these organizations that could bring a change not only amongst the medical profession but also the society?
Well, I mean, having these leadership positions, of course, your attempt is the to see that you can the basic purpose is you want to upgrade the knowledge of your members so that they can pass it on to their patients during treatment. The knowledge must be updated. They should be aware of the recent advances that are taking place. They should be aware of newer technologies, newer instruments, and everything so that they can make use of it for their patients. But besides all this, and I mean, of course, we used to have high quality conferences, workshops, CME programs, webinars, and certificate courses. But my priority was the young generation. We
Yes.
thought that we must take care of the younger generation because we have gone through the whole of our life now, and we have to see that we make a good career for these youngsters. I thought that these societies uh, I mean, must do their best for the youngsters who are their members and to attract youngsters to become members if they are not.
Hmm.
I strongly feel that the future of any specialty lies in its youth. So I always work to bring them up, giving them, I mean, appreciating their research, giving them chance to present their work, give them lectures, giving them to chair sessions, speak and lead. So all this I try to, I mean, I encouraged youngsters to uh, I mean, I would say about say 30-40% of the presentations we started giving to these youngsters gradually.
Oh,
We
yes.
started from small things, 5 minutes, 7 minutes, 8 minutes talks, but
Yeah.
gradually I found in about a decade that these younger people they become dynamic pulmonologists. They were taking very good class lectures
Great.
and they were getting involved in research, doing very good work. And I was so happy that perhaps we have been able to infuse some interest and knowledge and other things into these younger pulmonologists. So that is how means my vision was that. we must bring them up, not let them develop and remain at the bottom so that they take another 10, 20 years to come up. And
Right.
my hope has always been that every doctor feels proud to be a pulmonologist as far as their association is concerned, and and that they treat every patient very confidently with the best scientific knowledge, the current knowledge that they must acquire. So that was basically
Right.
as I thought about my role in these medical bodies. Yes.
Great, great, sir. Great vision. As in Foxy, we also have a young talent promotion committee, and we have Foxy Yuva,
That's
East
very good.
Zone, North Zone Yuva, Foxy conferences also.
That's very good. Yeah.
Yeah, sir, you have done the implementation of the National Tuberculosis Program and other. So you had a major role in that. And what efforts were done by you in this direction at your level? You have also undertaken a charitable mobile project on TB detection and the treatment in the rural areas of the Kanpur. Please share some details in this your ambitious project.
Well, as far as the National Tuberculosis Control Program is concerned, um, uh, we the tuberculosis is rampant in our country. We get about 27 lakhs new cases of tuberculosis every year in the country.
Yes,
And the biggest problem is that they are becoming drug resistant, what you call it, multi-drug resistant. They're
yeah,
becoming, they're getting XDR, TB, extensive drug resistance, and now even TDR, the total drug resistance. They're resistant to everything.
yes,
So the government has taken up this very seriously, and they have started this revised control program. Now,
right,
my role in this control program, to be very to be to be to be very true, I have been a good critic of this
oh,
program. So I was
right,
trying to find out, because such programs, if they've got some fallacies,
right,
they will not attain the same success that they should. What is their aim?
of
So I was
course,
trying to find out what problems, what things are lacking,
right,
where when say like uh, uh, the kind of chemotherapy being given, was it okay or not, and other facilities that are being extended. So I've been trying to guide and give my suggestions through associations to see that this program, because this is the last chance that we can control tuberculosis,
great.
and we must all contribute to it. And if
Mm,
we don't do that, perhaps this disease will it has been on this earth for centuries,
mm,
I mean, we'll not be able to get rid of this disease from this country.
sure, sure.
And it's such a big problem that it destroys families, kills
Mm,
people,
mm,
and people do not have the treatment is long, they cannot take treatment. So this program is a very ambitious program, and we should see that it runs so well and does good for the society. So
right,
we were trying to find out what are the shortcomings, and trying to bring them forward so that they can be followed and the program becomes perfect. So that was as far as the national control program is concerned.
right.
And then
Great role.
the it's very near to my heart, the mobile tuberculosis detection program. We
Okay,
started this somewhere in the year 1992, when there were no existing facilities from the government, not much facilities from the government sides to control tuberculosis. So
great,
with the one of the NGO, like we took help of Rotary Foundation,
right.
and we could get a grant of about 1.25 lakh dollars from
Oh,
them
oh,
through a local club, and they
oh,
also invested
great.
the same amount.
अच्छा।
So we wanted to run a mobile project, and we could get a van, a bus, full bus, fitted with X-ray equipment, a dark room in it, a lab inside it, PFT, and audio-visual aids for health education. So we were, and it also had a 10 kVA generator
Oh,
to, because when we go to the villages, you don't get electricity, proper electricity. So the
oh,
generator backup to run your equipment, and a jeep to transport the staff. So
oh,
we'll go to the one village, station the vehicle there. My staff will every day go there.
right,
We'll do a door-to-door survey.
right,
We'll enroll all the family members in every home. Then the
right.
doctor's team will follow. They will examine every individual. We'll use things like tuberculin test, sputum test, X-ray
Oh,
test, and whomever
right.
we diagnose having tuberculosis, we'll give them free treatment,
Oh,
and not only one-time treatment, giving
right.
treatment for the entire duration. So
Oh,
we'll
sure.
pass on from one village to the other and make clusters of these 4 or 5 villages at one place, and many such clusters were created.
Oh,
I think we worked in about more than 1,000 villages,
oh, so
and
great, great social
about
work.
5 lakh population was covered, and we could provide them all facilities, modern facilities, latest treatment, latest investigations, and giving them treatment till they were cured. And
Okay.
for 10, 12 years, not even a single day that the program did not work. That
Oh,
was the credibility. And that was not the end. We also involved, through the department, we involved students for their thesis, for their, so that they can go to the villages and learn over there, learn these patients in the rural environment, so that
right.
in future when they have to go to the village to work, they don't have any kind of hesitations. They can go and work there. And we
Sure.
have we could should involve about we could work on about 25 thesis topics
Oh,
from this project,
oh,
and several research papers were published, and where presentations were made, and even we had Moscow University sending their one of their research scholars to do the MD,
oh,
for their MD. They chose our department in this rural work to work on a thesis for their MD for that particular student. So it was a kind of they wanted to develop a computerized program for monitoring of tuberculosis, and in anywhere in the world, because they wanted to devise a kind of computer program, because computer was something new at that time. So that is how we not only did service, we also did research, and we also involved postgraduate students to work and go for their studies on these rural patients. So that is how we could run this project for almost about 12 years. We were running, we run this
great.
project.
So I think everybody should know you have such a great vision and such a great social work. I think कभी भी tuberculosis का ये जब अंत होगा तो you should be one of the great pillar for this, because as we hear that a great work has been done by you, sir. Hats off to you.
Thank you
हम
so much.
सबका शत
Thank
शत
you.
नमन and pranam.
Thank you.
So, you have also done the projects on the control of smoking in the school children.
This is another
Please
subject which
give
is near
some
my heart.
details
Yeah.
on it. Yes, yes. What is the first hand, second hand, and the third hand smoking?
Well, smoking perhaps kills many people. I mean, we are not aware of this fact. 6 to 8 million deaths occurring every year due to smoking related causes.
Oh,
And it is thought that perhaps in this century, 1 billion people will die of smoking related diseases.
right.
And it is also seen that smokers usually die 10 years earlier than non-smokers. Their life is curtailed by about 10 years.
Right.
And this smoking usually starts at the age of 12 to 16 years when the people are young, the students,
Oh,
because they are they do not know the hazards of smoking, the hazards of
hmm,
tobacco.
that is important.
And mostly people will target smokers to stop smoking. But that is a difficult thing because not that it has not to be done, it has to be done. But perhaps what I found was it will be more paying, more fruitful to not to let youngsters pick up smoking
Yes.
rather than making those people who are nicotine addicts
Hmm,
smoking free. That is a much difficult task.
very
So we
difficult.
went to several schools with a very good audio-visual program
Great.
telling students the hazards of tobacco, that
Yes.
how
Great.
it can
Great.
harm them,
Hmm.
and to the extent that we wanted to tell them that they do not have any knowledge about basic knowledge
Yes.
about cigarette or about tobacco. So we wanted to educate them so
Hmm.
that by their own choice
Yes.
they will never take up this habit. That was our basic aim
Okay.
when we did. And not only that,
Right.
we also educated them that if their parent or somebody at home is smoking,
Hmm.
that is harmful to these kids. They should also know about that thing.
Yes.
And uh, 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 we gave them we asked how many of these students have their parents are smoking. We gave them a very emotional letter to be signed by them, given to their parent, that if you are
Great.
smoking, you are such a, I
Great.
mean, I love you so much. I mean, to his a letter to his father. I love you so much. I don't want to lose you. And simultaneously, I also do not want you to harm my health. So that kind of a letter was also designed. We gave them badges to put on them that we are tobacco free, and a lot of many things, activities were done to see that these students, young students, do not pick up this habit.
Yes.
We just to tell you, in India, 1 million people die every year.
Because of tobacco.
2740 every day, 2740, 114 every hour, and 2 every minute. So that in our this program in 60 minutes, 120 people will die in India because of smoking.
Hmm.
And
बहुत दुखद
if
है.
you go by data, then 5 million children, 5 million youngsters between the age of 5 to 15 years are
Hmm.
smokers in India.
Hmm.
That serious is the problem. So that it's not that that youngsters are not the target of they do not smoke. There a lot of them are in our country are involved in this. Then perhaps many people will not know that a cigarette smoke has got 7,000 chemicals in it,
Hmm.
1,000 out of which are toxic, 70 are carcinogenic,
Oh.
can cause cancer not only of lungs, but cancer of perhaps any organ like larynx, lips, urinary bladder,
Hmm.
GI.
Hmm.
When you name any organ, the cancer can be caused by cigarette smoke.
Hmm.
And so a person who smokes, we
जी.
call him as a first-hand smoker.
Okay. Okay.
He smokes directly. The smoke goes inside him, and he's exposed to all those chemicals and carcinogens that he has. And then is the second-hand smoke. Second-hand smoke is the mainstream smoke which goes in a person, and then he exhales it out.
Yes.
And between the puffs, the cigarette keeps burning,
Oh.
and that burning of cigarette also releases smoke, which is much more dangerous
Oh.
than the mainstream smoke.
Oh.
So the side stream smoke is still more harmful. They say it has got It has got more of nicotine, it has got more of tar, it has got more of carbon monoxide, and more of ammonia and more of carcinogenic substances.
Oh,
So this second-hand smoke is very dangerous. And smoking, as far as your specialty is concerned, a smoking mother, if she is pregnant,
right.
she can have more birth in the child when the newly born will may have more birth defects.
Birth
It may be
defects,
a premature stillbirth.
premature
It may
stillbirth,
be a low birth weight.
low birth.
SIDS, that is sudden infant death syndrome. You must have known about that.
Yes, I
Smoking
remember.
perhaps is a very important cause of it.
Yes, yes.
Lowered immune status. Perhaps
Lower.
these children often develop asthma also during their childhood. And
Yes,
after delivery, the lady, when this is during pregnancy, and
right.
once the child is born, then again he is exposed to his mother if she is smoking, and can lead to poor growth of the lungs, more
Oh,
bronchitis, pneumonia, asthma, SIDS, increased risk of cancers as well. So this
okay.
is about how the second-hand smoke can harm others, and any kind of smoking, whether it is cigarette or it is hookah or it is chillum or it is whatever it is, even these electronic cigarettes which are coming up.
Okay.
Earlier they said that these are safe, but they are not. They are equally harmful. So even these electronic cigarettes are not safe, neither safe for the person who smokes, nor
Right,
the
right.
person, the second-hand smoker. And then now what you said, the third-hand smoke. It is the residual nicotine and other chemicals
Yes,
which
sir.
go into the atmosphere, and they settle on
Oh,
surface of clothes, furniture, drapings, and
okay.
beddings and carpets everywhere. Inside a car, if a person is smoking the car, it is present there also. And
Oh,
these chemicals, by touch, they can get inside, especially the children. They've got a
yes.
habit of putting everything in their mouth. So
Yes.
these carcinogens, these chemicals can go into them, and that is why if you, like in a hotel, if you are going to a room which is smoker's room,
Okay.
these chemicals are there, present there, and they become harmful. So this is what is called as a third hand smoke. So smoking is something which is very harmful to our health, and we should see that this I mean, if we want to save our population, we've got an epidemic of smoking going on in our country, and we must save our youngsters and other people who have got this, who get into this habit.
सर, बहुत ही मतलब आपने पुख्ता जानकारी दिया हम लोग को स्मोकिंग के बारे में। मेरे ख्याल से इसकी अवेयरनेस होनी चाहिए, हर घर तक पहुंचनी चाहिए, पूरे कंट्री वाइड ये एपिसोड हर एक को बार बार सुनना चाहिए, सो दैट दे शुड गेट अ ग्रेट नॉलेज फ्रॉम यू अबाउट द प्राइमरी, सेकेंडरी एंड द टर्शरी,
Third smoke, yeah.
या थर्ड हैंड स्मोकिंग, एंड ट्राई टू अवॉइड देमसेल्फ। प्रेगनेंसी में भी आपने जैसे बताया, क्योंकि हर व्यक्ति पहले अपने आप को फिर भी कंट्रोल नहीं करे, जब बताएंगे कि ये बच्चों पे अफेक्ट कर सकता है, then they will be more conscious and obeying it. So,
Yes.
thank you for highlighting few points. Because we have less time, so we quickly come to the other question on the genital tuberculosis. Sir, according to you, because we Foxians, we gynecologists are more concerned about the genital tuberculosis. So, what is the current burden of the female genital tuberculosis in India? Do you feel it is still an undiagnosed disease?
Yeah, true. In fact, extrapulmonary, I mean, we have got such a high prevalence of pulmonary tuberculosis, and
Right.
so that extrapulmonary tuberculosis cases are also going to be very, very high. It's about worldwide, it is about 27% patients will have extrapulmonary tuberculosis. And out of these 27% of the extrapulmonary tuberculosis, about 9% are going to have genital tuberculosis. So it is one of the very high side
I.
figure for genital tuberculosis as a part of extrapulmonary tuberculosis.
Right.
The In fact, the genital tuberculosis is underestimated. It goes very often goes undiagnosed because many of the patients are asymptomatic. They do not have any symptoms, and very often it is only detected once a person gets married and the problem of infertility comes up. Then they are investigated and they have found that they are having genital tuberculosis as the cause of it. So we do not yet know what is the prevalence of genital tuberculosis, because many times it doesn't show up. And as far as infertility is concerned, they say in India, 3 to 16% of the patients, the cause of infertility may be because of genital tuberculosis.
Genetic tuberculosis. As an infertility specialist, even sir, I also see in my practice कि बहुत सारे cases genital tuberculosis, स्पेशली जो secondary infertility वाले patients हैं वो genital tuberculosis लेकर आते हैं, and by treating them they get pregnancy, they conceive. And so which investigations are
But
considered?
even after treatment, many of the patients with genital tuberculosis may not have a normal delivery. They
Many
may
times
have pregnancy, but they may also have ectopic pregnancy and miscarriages. And
because of
after,
blocked tube and altered tubal function, we have to do IVF. Even after many times there
yeah,
is
you
endometrial
have to take aid.
atrophy.
Many of the patients may not have a natural pregnancy, but they may have to have some
IVF
kind of assistance. Assisted
assistance.
pregnancies have to be, yeah, that could be the answer for them.
Many times there is endometrial atrophy. We have to infuse stem cell, PRP, etc., and many other method to get the endometrium growth. And then we do the IVF. Many times it has happened in even my patients also. So coming on the investigation, because we have a less time, so I am merging few of the questions. Which investigations are considered the most reliable for diagnosing genital tuberculosis?
Well, clinical history has got its own place.
Right?
We must have a high index of clinical suspicion in a case. Then only we'll be able to detect genital tuberculosis. And looking for a primary site, whether it may be in lung or maybe somewhere else. If you find an evidence, say in lymph nodes or in some other organ, perhaps the chances of having genital tuberculosis, the genital tuberculosis will would be more. But the going investigation wise, the pathological confirmation is important, but is difficult because it's a paucibacillary disease. The number of the bacilli in the lesion are less. But
Yes.
with the help of, I mean, you can subject the tissue, the like endometrial curettage or the menstrual blood can be subjected for pathological confirmation, but the outcome may be not good. And let me also emphasize that gene expert, this new test is very sensitive and should always be used. But even with the gene expert, the output would be around only about 4 to 14%.
4 to
Then,
40%.
yeah,
That is
earlier
very important.
gynecologists were taking a lot of help from serology, but
Yes.
serology has got no role to play in the diagnosis of genital tuberculosis.
You're
Then
right.
you must exclude tuberculosis in other parts of the body. Tuberculin test may have a limited use.
Right.
Imaging techniques like ultrasound or CT or MRI or hysterosalpingography, ultrasound, CT, MRI to for external appearances, and hysterosalpingography for the internal view of the genital organs, what kind of defects are seen there. And then, of course, laparoscopy is going to be very helpful because not only visualization, but you have a chance of taking a biopsy also. So histopathology can be done from with the help of a laparoscope. And when you're when you're taking a tissue, my advice would be don't only get histopathological tests done, but also get a gene expert done on that tissue. That may, if you do get the two things together, the yield may be sometimes higher.
My
Then
question is, sir, in case there is a tubercle, then taking the biopsy, or from the normal appearing peritoneum, we can take the biopsy.
I think once you have gone in, you must always, I mean, it's always because it's under direct vision.
Right.
If you can, if under direct vision, all those areas which looks suspicious of tuberculosis, the highest yield would be from there.
Yes.
But even if you have gone in, you must, before coming out, if you don't see any such area by naked eye, even
Yes.
then it
We
will be
can take the
advisable to
biopsy.
take biopsy pieces. Yes.
Great. Great, great.
And if the patient has got ascites also, ascites, localized ascites or generalized ascites, that also should be investigated for all these bacteriological confirmations. Yes.
In ascitic fluid, do you find any bacteria, etc.? No?
The yield is low again. Yield is low, but
Again.
you may.
Yes, yes.
But
So,
say ADA may be helpful, and the cell count, what kind of cells are present there, more lymphocytic predominance would be seen there, so and more of proteins and exudate. So all these things may help in making may be helping in making a diagnosis.
so thank you for elaborating all this. Although there are a lot many things which you have told, but always there is a suspicion that should be kept in our mind, because in this is a possibacillary disease, as you told. So in many of these, even after being the disease positive, we miss the diagnosis by all this, because but we can suspect. So,
Yes.
in case the patient is on treatment of the tuberculosis and she conceives, so what about the modern medicine? What is the medicine which should continue after she conceives? Or what is your recommendation about the pregnancy with the
So
tuberculosis?
if the patient conceives during treatment of genital tuberculosis,
Right,
the treatment must be continued till the duration for which this treatment is planned is completed. That's
right,
one thing.
right.
Secondly, if a case patient of pulmonary tuberculosis becomes, I'm telling you the other thing. If a patient of pulmonary tuberculosis during treatment gets pregnancy,
Right.
then also, our advice is always to continue with the anti-TB drugs and not go for, because earlier thinking was that should these patients go for an abortion or not. The primary drugs, the rifampicin, INH, ethambutol, pyrazinamide, they are safe
Yes, yes.
for pregnancy, and they can be given to all these pregnant patients. So that is not a real risk. It's drug like streptomycin and amikacin,
Should
which
not
should
be
not be
given.
given. Ethionamide is teratogenic, it should not be given.
Should not be given.
Fluoroquinolones like levofloxacin, moxifloxacin, they should be avoided during pregnancy and during breastfeeding.
Right. Right.
And we do not yet have much knowledge about the newer drugs which are coming up for drug-resistant tuberculosis like bedaquiline and delmonate, etc. They
Okay.
should not be, we do not know yet how safe they are. But these primary drugs, which is required for most of your patients, isoniazid, rifampicin, ethambutol, pyrazinamide, they are safe and they should be safely, be patient be advised to continue with this treatment. There's no harm at all.
Sir, yes. So this is a message for all of us. Ki, once a patient of pulmonary genital tuberculosis conceives, the medicine which are safe can be continued and should be continued till the course completes. So course may be of 6 months, of 9 months, but the course should be
Completed, yeah.
completed.
Completed.
Yes, sir. Thank you. You have also been involved in lot many research works and have published several research papers. Please, in a short,
We are short of time now.
short of
The only
time, yeah.
thing I'm basically two researchers which have gained a lot of popularity. One was giving high dose isoniazid to patients of MDR tuberculosis, because normally isoniazid is not given once the patient has got MDR tuberculosis. But
Right,
we tried it in a dose of 16 to 18 milligram, and we found that it is going to be, along with other drugs, of course, other second line drugs, and
right.
we found that this is going to help these patients. And this research was published in International Journal of Tuberculosis and Lung Disease. And immediately the same year, WHO picked it up and included in its guidelines for drug-resistant tuberculosis. And they
Great,
continued,
great.
yes, it was and then in all their subsequent
Appreciated.
guidelines, they have been, they referred my name and included this. Not only that, International Union Against Tuberculosis and Lung Disease they also included in their guidelines. European countries also, they made consensus statements saying that this should be implemented. Indian guidelines, of course, the revised National Tuberculosis Control Program also includes it. The guidelines from API also include this as a recommendation.
Great
So
research.
that was one work which has got a very positive aspect, that it was implemented world over. And
Oh,
the other thing which we have been working, was about giving anti-TB drugs through inhaled route. And we find that this may have a very good scope, not only in the drug-resistant tuberculosis, not only in pulmonary tuberculosis, but in drug-resistant tuberculosis as well. Because if we put in the drug directly into the lungs, I'm talking of only pulmonary tuberculosis, not other extrapulmonary tuberculosis.
जी,
The
inhaled,
drug goes
inhaled.
in
Yes.
and creates a very high concentration inside the macrophages where the tubercle bacilli reside,
Okay, okay. Great
and
research.
also in the extracellular fluid.
Great
So
research.
with that high concentration, it can quickly kill them. Even the resistant organisms will be killed. So this was again a work done by us, uh, which, which was presented in international conferences and published also. And this has got a it is great promise, and perhaps and potential as well, and may be very useful. And
Okay.
lately, we have released guidelines on nebulizer therapy with 69 experts. We were from all parts of the country. We worked up a guideline which is a 191-page document which is published recently in 2022 December. And
Great.
299 recommendations have been made, and it has been very well accepted all over the world. So
Great.
basically, I like to highlight these three works which were of a great importance.
Sir, so thanks and great regards. You have given us too many words of the wisdom and the knowledge, and one-liner message to all the 46,000 Foxians which have joined today.
Well, I can't show any light to them, but I would like to say that may our collective skill, compassion, and commitment continue to shape a healthier, stronger tomorrow for every woman we serve.
Thank you very much, sir.
Thank you very much.
शत शत प्रणाम, नमस्कार, और आपका जैसा एफर्ट ईश्वर
Thank you
हम
so much.
सबको दे, एंड यू आर ए ग्रेट आइडियल फॉर
And
ऑल
my
ऑफ
best
अस.
wishes to all of you for a bright
Thank
and
you, sir.
fulfilling professional journey ahead.
Thank you, sir.
Thank you very much.
Really, I am blessed. We all are blessed by the presence of such a legendary figure.
Thank you
Thank
so much.
you. तो
Thank you.
ज्वाइन करिए हम सबको रोज
Thank you.
फॉक्सी के साथ. थैंक यू.
Thanks a lot. Thank you very much. Thank you. Bye bye.